Dan the man, sir. Bro, first of all, it's been a pleasure to meet you. I love how everything works, and we kind of just came across by a suggestion from someone else, and we've just been hanging out for a little bit now. So first of all, pleasure to meet you. Thank you for coming on, man.
Definitely love meeting you, man. Honestly, love what you do here.
Yeah.
I'm loving the content. I love the fact that you interview people. Mm-hmm. I want to see a lot more of this stuff coming out, man.
Yes, sir. Yes, sir. So you have a special career going, especially in this time that we're living in. RT, everything to do with breathing. There's a bunch of slogans. I can't breathe. People being sick, lung issues. You are an RT. I would love to know about what an RT is, what they do, kind of your schedule, the ins and outs of an RT. Obviously, why you chose to do it, and then maybe some tips and other things for others in school, and maybe they don't want to stab somebody with a needle or whatever, and RT might be a way to go.
So I'm a respiratory therapist.
Mm-hmm.
This career has only been around for about 50 years officially.
Really?
So that's one of the big differences between respiratory and nursing, by the way, which most people listening to this are familiar with nurses.
Right.
Not that many people know respiratory. So respiratory is something that started because of a need for people that specialize in just the lungs. Mm-hmm. So nursing has been around for over 100 years. Mm-hmm. It's a much more established career. And then all of a sudden there was a need for people to help with breathing treatments, with oxygen delivery, and just focus on that. Mm-hmm. So because of the need, a group of people got together and they kind of formed this career called respiratory therapy.
So it's like more of a specialized career.
Yeah. So initially, do you know anything about iron lung?
I've never heard of iron lung.
Okay. So iron lung is a thing that was invented about 100 years ago. Mm-hmm. So pretty much, I guess I got to explain my career before we get into respiratory mechanics. So my career focuses on just breathing. Okay. Everything to do with the lungs, everything to do with the respiratory system. Mm-hmm. And so because of that, we specialize in a lot of weird things. Okay. And one of those things is breathing mechanics. And what breathing mechanics is the ability to breathe for someone. Mm-hmm. So what we do, one of the things we do is we put a tube inside of your throat. Mm-hmm. We tape it up to your face, or we use a little Hollister, and then we hook you up to a machine, and that machine breathes for you. Okay. So my job as an RT is to make sure that you're actually ventilating properly and making sure you oxygenate properly. Okay. So whenever you're watching a movie and somebody says, "Oh, this person's on life support," well, life support is actually my ventilator. That's what life support is.
So life support is the machine breathing for the person.
Yes, and so that's one of the main things of our career. That's one of the main driving factors of our profession, is that somebody needed to control that machine. Okay. So a nurse has to insert drugs in the IV. A nurse has to pretty much take care of the rest of the body. Okay. The dynamic of a hospital typically works like this. The doctor oversees the whole list or the whole bunch of patients. Mm-hmm. And the doctor tells the nurse what to do. And the nurse is pretty much the hands of the doctor. Mm-hmm. So the doctor tells the nurse what to do. The nurse acts on it. Okay. And for a long time, that was good enough because the technology wasn't there yet for breathing and for other things. Mm-hmm. Once medicine began to advance, there became a demand and a need for people to specialize in other things. Mm-hmm. And out of that, we got radiology. Mm-hmm. That's something that didn't exist in the beginning. We got other professions out of that. And one of those things that came out of it is the ability to control mechanical ventilation, which is the ability to help breathe for someone.
Okay, so the sole purpose of breathing is to push oxygen through to all your organs.
So that's actually a big misconception that a lot of people have. So the reason we breathe is not even for oxygen. That's actually not how we breathe. We breathe because of CO2. You know what CO2 is?
Right.
So carbon dioxide is it's a byproduct of cellular metabolism. That was a mouthful. Cellular metabolism is you pretty much walk around, and the byproduct of you walking around is you create a lot of CO2 as an excess. That's like the waste of your cells. Okay. And that CO2 needs to leave your body because the CO2 starts building up, and it creates your blood to be acidic. Now, when your blood is acidic, just like, let's say you're marinating a steak in alcohol or you're marinating in some kind of citrusy thing, the actual acidity breaks down proteins and it makes it more tender. Okay. The same thing happens in your blood. When you're building up CO2, the blood is getting more acidic. And when the blood gets more acidic, what happens is your proteins in your blood start to uncoil.
Dude, that's interesting. I just heard literally David Blaine talking about the fact why he's able to hold his breath for so long. It's because how much CO2 your body can handle. It's not how much oxygen you can hold.
Exactly. That's the mechanics of ventilation. So one of the interesting things about that is they found recently that in drowning victims that drowned in cold water, there's been people that drowned for, I don't know if it's 40 minutes or 30 minutes. They've been underwater submerged, but because the water was so cold, when they pulled them out, it was as if they were fine. And so one of the things we do after we do CPR, we actually put people on a cooling blanket to bring their body core temperature down, because that slows metabolism and that slows CO2 production.
Okay. Wow, that's interesting.
So the reason, for example, a snake or cold animals can eat only once like a week, you know what I mean? Is because their bodies are colder and they don't actually produce enough CO2 where they don't need to eat a lot to regenerate energy. It's all about the body's ability to generate energy and regenerate energy and excrete energy.
Dude, that's super interesting.
Yes. Now, so
wow.
With that being said, the reason we breathe is to breathe out the CO2.
Okay.
And as a byproduct of that, we breathe in oxygen. To make things even more interesting, actually, I'll say two interesting things in my opinion that are interesting. So CO2 production starts increasing, and we have a receptor. It's right here, right around the lungs. And it actually senses how acidic your blood is. And what happens is it sends a nerve. The higher acidity it is, the more it sends a signal to your brain to control the part of your brain that controls breathing and tell it to breathe. So what happens is when your blood gets acidic, there's a signal that keeps firing, telling you to breathe more. And so you don't even think about it and you start breathing more. And that's how we could tell somebody's having a problem, is that when they come into the hospital, they start breathing pretty heavily.
Okay. So now I'm thinking of somebody running and they're breathing like crazy. It's not because they need more oxygen, it's because they're trying to get rid of more CO2.
Exactly. That's exactly why we breathe. And again, it's one of those things that before I was in respiratory school, I thought we breathed to get oxygen. And then once I was in school, they're like, don't worry about oxygen. Worry about the CO2. That's what will kill the person. Now, oxygen is something that we worried about, especially with what's going on with the pandemic right now. That's actually the biggest issue is oxygen. But another interesting thing is when somebody has COPD. Have you ever heard of COPD?
Nope.
No. Okay. So COPD is actually... it's called chronic obstructive pulmonary disease. It's like the number 2 or 3 killer in the United States. So a lot of people, let me tell you one thing. A lot of people think smoking causes cancer and that's the number 1 killer is cancer. It's actually not. It's COPD. Okay. So everybody that smokes has like a 95% chance of getting COPD. Okay. And there's it's a chronic obstructive pulmonary disease. There's 2 main diseases you get. You get chronic bronchitis or emphysema. Emphysema, what happens is your airways get so frail over time because of all the smoke that you no longer can breathe out. So you actually become more like a balloon. You have no ability to breathe out. Have you ever seen those really skinny older grandpas, but they have these chests? They look like they've been working out. That's called barrel chest. It's pretty much a big balloon. Their lungs are just inflated. Really? Okay. Yeah. Now, with that being said, in a COPD patient, because the person smoked for so long and they're not able to breathe out the CO2, their lungs are just a balloon and they keep all the CO2 in. Their brain switches over to oxygen, and the sensor that I was telling you in your body that your body has, that little sensor now switches over to oxygen, and that's how you start breathing with them. So what's interesting is for a COPD patient in a hospital, when you actually give them oxygen to help them out, that can kill them. They'll stop breathing. Wow. That's a common thing that happens in the hospital.
That's crazy. So right now in this pandemic, when they put people on a respirator or something.
Oh, I hate that word.
Okay.
Sorry. It's kind of like it's like a mechanic and somebody's saying the wrong thing. Or,
okay, well, what is it?
A ventilator.
Okay, sorry.
No, it's everybody says it. It's funny.
Okay, so they put a person on a ventilator, and they're saying like you have a higher chance of dying on a ventilator. Is that it's because the oxygen is messing up with the person, or? So
with what's happening today, it's a completely different situation. Okay. Now, with what's happening today is. I actually made a video about it on my YouTube channel, and it's ARDS. Have you ever heard of that? Nope. Okay, so have you ever heard of? Do you know what pneumonia is? Yes. Okay, if you were gonna explain pneumonia, the simplest way to put it is it's inflammation of the lungs. That's actually what it is in Russian. Воспаление легких.
Yeah.
So when your lungs actually get inflamed, that means they swell up. And when they swell up, the gas exchange can't happen. So CO2 cannot leave the blood and oxygen cannot enter into the bloodstream because of the swelling. So what happens is in ARDS, it gets so bad and thick that there's no more ability for the oxygen to come into your bloodstream.
Okay, so the lungs swell so that the volume of air, the chamber is smaller pretty much.
That's one problem. So your lungs are stiffer. Second problem is you have a very thin line. So an air sac in the lungs is called alveoli. That's pretty much what our lungs is, just little balloons. It's actually after a grape. It looks like little grape clusters.
I saw you post that, yeah.
Yeah, and so you get the little grape clusters. It's so thin that an oxygen molecule can easily pass through the membrane, and then it has gas exchange. And I'm not going to get into the dynamics of it, but it's very fascinating. It literally just works because there's iron in your blood, and the oxygen is just drawn to the iron.
Wow, dude, that's amazing.
So with that being said, though, the wall, once it starts getting thicker, the magnet of the iron inside your blood in the hemoglobin can't draw out the oxygen from the inside of your lungs. And when it can't draw out, it starts using up your oxygen and you start depleting your oxygen source. So when it gets so bad in the hospital, we have to put a tube inside you and control your breathing. And we actually put you on a thing called PEEP. It's pretty much inflating your lungs like a balloon.
Okay.
So when we put patients on a ventilator at the hospital that have what's going on right now, the biggest problem why they say people don't make it is because if we put that on you, that means you're pretty critical. So it's like a last resort kind of. It's not that kills you. It's that you're so critical that nothing else will work.
Okay.
Now, one of the things that sucks is a lot of people don't understand that because of the news.
Yeah.
And so people will come in and they're like, I don't want the tube because I don't want to die. And we're like, you're going to die if we don't put a tube. And so many of the patients that have a tube come out of it and they're perfectly fine. We've actually successfully extubated a lot of people and they're at home right now.
Okay. Thank you.
You're welcome.
Yeah.
So yeah, that's pretty much, that's what's going on right now. So the respirator, AKA ventilator, doesn't kill people. It's the last resort to save their life. But they're so bad usually, especially with what's going on, that we just can't do anything about it. Like the only other thing that people try to do, it's called an ECMO, and have you ever heard of dialysis? So dialysis is like a filter for your blood. But what we do it's called the ECMO, and it's a filter for your blood to oxygenate it and to get the CO2 out. So it's like external lungs.
Okay, gotcha.
There's only a few of them in Sacramento. There's only a few in each city.
Really?
Yeah, there's only a few of them.
Are they super expensive or?
So expensive and very difficult to make, very difficult to manage. It's like it's the last resort for everybody in every hospital, pretty much.
That's crazy, dude. I'm still kind of mind blown about the fact that you said the only reason we breathe is because of iron, and I'm just like, dude, that's why everybody always says make sure you're iron. Well, without iron, you can't exchange the gases in your lungs. And I was just thinking about that the whole time. That's super cool, dude.
He's getting epiphanies over here.
Yeah, dude. It's crazy how everything just works together.
So one of the cool things about respiratory is that you learn about things that you normally wouldn't learn in like nursing school, because the focus in nursing school is more patient care, as in like, I'm going to make them feel comfortable, make sure they're not in any pain, give them their medication. As a respiratory therapist, I just make sure they don't die. That's my only focus.
Okay.
So what's cool about the profession that I'm in is that because I have such a highly important job, I get to learn a lot of things that most people don't actually think about. So let's say CPR. That's something that a respiratory therapist on a shift might see 3-4 times a night, as opposed to like an average nurse, other than the ICU. Do you know what an ICU is?
Intensive care unit.
Intensive care unit is pretty much the most critical patients. Outside of that, a nurse might do CPR once a month. And so because you see that, you actually interact with a lot more intense situations, and you get to learn a lot of cool stuff. That's one of the cool things about being an RT.
Yeah, that is cool. How do you tolerate the stress levels with all these critical patients? Does it affect you?
So I think, the funny thing is I think everybody in the medical field, they develop this callousness almost. You almost have to, you're humor becomes a little bit more dark.
Yeah.
You just kind of become a little weirdo, you know?
Yeah.
Like I'll come home sometimes and what would be a normal conversation in the break room at the hospital, my family is like, what's wrong with you, man? And like, what's going on? So, I mean, I think that one of the best ways to deal with stress for most people is just when you go home, you forget about it. That's kind of one of the cool things about the medical field is you do a few days at work and then you go home and you just completely leave the hospital, leave that behind. A lot of professions, they take their work home with them. That's one of the cool things that helps us deal with that, especially with people dying. Right. But I think it takes a certain kind of person to be able to handle death. I mean, you're going to see, in my profession, you're going to see death very commonly, especially with extubations. You know what that is?
I'm guessing it has to do with the machines that you put the people on, the breathing machines.
Yeah. So let's say the person is they're to the point of no return. They're just breathing because they're on a machine, and the family decides, you know what, it's time for them to go to a better place. So it's time for them to let go of them. And the person that has to take the tube out to let them go is going to be me.
Yeah.
And so it's like I said, at times when I worked at a trauma hospital, you would see people that were like 2 years old that were shot, or you'd see stab victims, suicides, very common. You would see car accidents where people are paralyzed and they don't know they're paralyzed because of the shock of the accident. And then the doctor asks them do you feel me grabbing your leg? And they're like, no, I don't feel anything. And you're looking at that and you're thinking to yourself, oh, just don't think about this. Just don't think about this. So it definitely takes a strong person to work in this field. And I think that's why it's such a niche part of the hospital. But I think if anybody's excited about saving people's lives, this is the way to go. Dude, this is that part of the hospital.
That does sound exciting, especially like all the knowledge you've just been throwing at me is super interesting, dude. So what is your typical day like or shift?
So cool thing about being an RT is that we do 12-hour shifts. Now, some people don't like that. I think that's one of the coolest things because you work 3 days and you're off for 4 days.
That is super awesome.
And having 4 days off is like a mini vacation.
It's like another life, dude.
Exactly. Especially if you're working the first 3 days of the week and then the last 3 days of the second week.
Yeah.
Then you pretty much have 8 days off. And you could actually book a vacation.
Yeah.
That's actually one of the big reasons why a lot of people become RTs is because of the schedule, which is kind of weird, but it's like, I like the hours.
But dude, that's cool. I mean, schedule affects your life. And if the schedule improves your life, well, then that's.
Yeah. And so I think 12-hour shifts are as difficult as they might be. You just get 3 days out of the way and you're off for 4 days. And I think that you get to spend a lot of time at home. You also get to pick up a second job, which a lot of RTs do have second jobs. That's something that a lot of nurses I know work 8-hour shifts. There are nurses that do 12-hour shifts too. But I think that when you have an 8-hour shift 5 days a week, you can't really pick up any hobbies or do any other things.
Right.
But with a 12-hour shift, you get to do a lot of things, So a normal day would typically look like you come into work and you're giving your patients, this is the same for anything that's patient driven. So like nursing is the same way. The previous RT gives you a report, which is like, this person has this going on. Their blood is this. The biggest issue is this. We have a CT in an hour. And after you give a report, you go see your patients. And depends on where you're at. And like I said, one of the cool things about being an RT is you get to be in critical places, but you also get to be everywhere in the hospital. Compared to nurses usually have 4 patients. They're usually on one floor and they're on that floor for a few years. So like, let's say they work med surg. You had somebody work med surg or tele. They're only going to work tele until they move to a different position. So they're only limited to working in that. And now it's not a bad thing.
Tele is the telemetry unit?
Telemetry unit. Okay. Or med surg is medical or surgical unit.
Okay.
And if they work in those units, they're stuck there. It's not again, I'm saying it like it's a bad thing, but you can't really go to the ICU one day or you can't go to ED or anything.
Okay.
What's cool about being an RT is that if I'm working one day in the ED, the next day I can get assigned ICU. The next day I can get assigned NICU, which is with neonates.
So much more diverse.
Yeah, we're all over the hospital.
That's awesome. So
like if you're tired of working in one place and you can just tell your supervisor, hey, I've been working in ED for 3 days now. Can you take me out of ED and put me in ICU for this week? And they could probably do that.
That's awesome.
So you get to actually always be in a different environment, and every environment in the hospital has a completely different way of dealing with the patient. And so depending on where you're at, you get report on your patients, and then you go see your patients, and then throughout the day, if you hear any code blues, you respond to all code blues.
Blue is
when you're cardiac arrest, cardio or pulmonary arrest. So when the heart stops beating.
Okay.
So usually they announce it on the big speakers, and they'll say there's a code blue in this room, and you pretty much drop everything you're doing and run to the code blue, and you're doing CPR for, depending on what's going on, but anywhere from 20, 30 minutes. I think some patients I've been in like for 2-3 hours
doing CPR.
Well, so you do CPR. Oh yeah,
you probably come home sore.
Yeah. As you can tell by my physique, I'm really strong and buff. From all the there's days where you come home and you're just like, oh my God, my neck hurts. What's going on? And you're like, oh yeah, there was a couple code blues today.
Yeah.
So typically, like let's say you did CPR for every 2 minutes, you switch out with another person. Let's say you're doing CPR for about 20 minutes, and then the heart comes back. The heart rhythm comes back. They have a pulse. You do what you need to do. They're on a ventilator, so they're good. They're stable.
Dude, how awesome is that feeling right there?
Honestly, there's been a lot of times where right in the middle, everybody, because we monitor, it's kind of complicated to explain, but we actually monitor if the person's heart rate came back by their CO2 that they're breathing out.
Okay.
So because I told you the whole point of breathing is breathing out CO2, when their heart starts beating again, on the monitor, we actually measure how much CO2 is coming out, and then the CO2 will spike up, and that means the heart's kicked in again. And so everybody will be like, I think we got rhythm again. And you're like, oh yeah, I brought them back,
Yeah, that's awesome, dude.
It's short-lived because you got to go see your next patient. But, so you're, the heart comes back after 20 minutes. And then let's say 5 minutes passes by or 10 minutes passes by, and the heart stops again. So you got to go in there and do it again. And then, there's times where you're there for a long time. There's times where you're there for just 30 minutes. It all kind of depends. I think usually after about 30 minutes, most doctors will kind of be like, look, let's just call it, because it's been 30 minutes of beating on their chest, and you break the ribs when you're doing it. It's like a very difficult thing to see.
Right.
And it's a traumatic thing for a patient too, just to experience. And so usually after a while, everybody's just like, look, I don't think we can do anything. Doctors usually will say, does anybody have any suggestions as to anything else that we missed? And if there's no suggestions, then they'll just call it.
Okay, man, that must be tough. I
mean, I would say it's usually tough. Like I said, you develop a callousness, and after a few years of working in the hospital, you almost kind of it's like a job. Yeah. You don't necessarily take the human out of it, but you need to cope with it somehow.
Right, just let it go.
You just kind of don't think about it, And in the moment, I've caught people like during, like I said, I've seen a few like kids die. That's usually the toughest. And like you kind of look around the room while you're like either doing compressions or doing something, and you'll see a few nurses crying, a few doctors crying, and you're just like, just hold back the tears, just don't breathe, don't cry, don't cry. But yeah, for the most part, it becomes a job. Okay. Where you cannot let your emotions get the better of you. Right. Because then you'll just be crying every day.
Right. You're gonna be focused on crying instead of saving people. Yeah. So if you're say you're pumping on a guy for 25 minutes and there's another emergency or another code blue, is there multiple RTs on a floor, or are you by yourself?
So usually depending on the size of the hospital, most hospitals you'll have at all times anywhere from 3 to 20, 30 RTs. So like some of the bigger hospitals that we have will have like 30, 40 RTs at once at the hospital. Okay. Some of the smaller hospitals will have 1 or 2. If it's only, the rule of thumb that we have is if you're the only one, then you're not beating on the chest. Okay. Then we're maintaining the airway only. And the thing is, once we secure the airway, once I can breathe for you, so we put a tube in you and then I breathe for you and I regulate your breathing. Other people will do the chest. And let's say there's another code blue that happens at the same time and you're the only one there, then you'll just ask someone to continue breathing, for you while you go do that. And that's happened before where, You got to run to the next place, and then you're there. You're like, all right, now hold this and breathe. I got to go back there, and you're just all over the place.
Man, that's crazy, dude. So is that how typical is a busy day like that?
It depends on where you work. If you work at a trauma center, like let's say you're working at one of the bigger hospitals that we have, and especially if you're in an ED, you're running around the whole day. Especially in other states, I would say again, depends on where you're at. But if you're in a busier hospital, that's your shift the whole time from beginning to end. If you're in some of the slower hospitals, like more community hospitals out like in the mountains somewhere, you're definitely going to be sitting down a lot more and not seeing this. And you'll actually kind of be waiting for that to happen, and finally they call it code blue, and you're like, oh, excited, I get to work finally, you know. What do I do? So you'll see that, I would say on average, most RTs will see that at least once a shift. You'll get some kind of critical thing like that to the point where your adrenaline's rushing and you just got to be thinking real quick. You got to be really with it. Okay,
that's awesome. So what is the craziest story that you've had? I'm guessing because you're an RT, your patients are sometimes or mostly not responsive, so you don't really develop, like you don't really talk to them ever, right?
So with what I was saying, that you get to switch departments, I've actually had patients where I was the one that I was the one in the emergency room when they came in with the ambulance. And I was with them the next day in the ICU, and I was with them all the way until they got discharged on the floors. So I was with them the whole time there. And it was funny because I was like, oh, I've been with you since the beginning. And they're like, oh yeah, I remember you from the beginning.
That's cool.
I would say most of your patients are actually there. A lot of the patients are going to be COPDers, people that they smoked their whole lives and now they can't breathe. That's probably the bulk of the patients that we have.
Really?
Yeah. And
so it's the older generation mostly.
So COPD is one of those funny things that nobody knows about. Like, have you heard about it?
Never.
Most people
I heard of lung cancer.
Yeah, and that's what everybody thinks, again, is the biggest problem with smoking. So let's say you smoked for 5 years, 5 to 10 years, from 15 to 25. And you stop smoking at 25 and you think you're good. You know, you're good. But the problem is you're still probably going to get COPD.
Really?
But you're going to get it at 50.
Okay.
Every COPD patient starts off seeing symptoms around 40 to 50. And it's how we determine it is we actually do a test to see how well you can breathe out. You're supposed to breathe out at least 80% of the air out of your lungs within the first second of breathing out forcefully. And if you can't, then you have most likely some kind of obstruction, which is the airway kind of collapsing on itself. So most patients have COPD, especially, like I said, all it takes is a few years of smoking, and not that many people know about that. And
dude, that's crazy. So even if you stop, like you said, way ahead of 50, it'll still catch up to you and affect you in the long run.
The bulk of my patients stop smoking in their 30s and they're 50, 60. And they're like, I stopped 20, 30 years ago. I didn't think this was happen. Like this could happen. And they can't breathe now. And it's pretty scary. I don't know if you've ever experienced not being able to breathe.
I have. One time I had a water fight with my brother and I slipped and knocked the air out of me, dude. And I thought, I was like, okay, I think I'm going, dude. And I just start praying. I'm like, Lord, forgive me, take me. And then I'm just like, I catch my breath. I'm like, oh, I'm fine. Never mind.
We're good, man.
No, but yeah. So I guess that was my closest call.
Okay, yeah. No, it's getting the wind knocked out of you is a pretty bad feeling. I would say that feeling of not being able to catch your breath is what they feel like, but for hours.
Man, that's bad.
Yeah, and so they come into the hospital. I mean, a lot of people come into the hospital, like I said, with higher CO2 levels. You start seeing that their body's trying to get rid of it. And so patients will come in breathing, typically will breathe anywhere from 10 to 20 times a minute. So every 5-6 seconds, you take a breath.
Right.
If you're sleeping, even less than that. These people come in breathing 30 to 40 breaths a minute. So it's like,
yeah.
And so with that kind of breathing, you can only do that for so long. Yeah. And then you crash. Your heart stops because you just can't handle it. The stress of doing it. It's kind of like, imagine being forced to run a marathon. And even after you run, 25 miles or whatever it is, you still forced to breathe again. That's what they are with breathing. They're pretty much running a marathon. There's a calculation you use, but they're using more energy to breathe at that point than the benefit of breathing is giving them.
Okay. So you're running, you're running into debt pretty much.
Yeah, you're just vicious cycle. It's just a positive feedback loop, and you're just keep getting worse and worse to the point where before my eyes, you see a person being wheeled in.
Yeah.
You see how they're breathing, and you're like, all right, we need to do something real fast. And then by the time they come in there, heart just stops.
That's crazy.
And then
dude.
so that happens quite often, I would say.
Man, that's a stressful job. There's definitely a lot of gratitude involved because it's super rewarding when it does work out, saving someone's life. Also super sad because oftentimes you can't save their life. And knowing all that craziness going on, why did you go with RT?
I wanted to be an expert in something.
Okay.
Honestly, that's funny because I thought about that, and I was kind of like, am I ready for this?
Yeah.
Like, I actually had a moment where I sat down and I was like, I could just go to nursing and I'll see a lot of this, but not as much of this.
Mm-hmm.
I think the feeling of being able to say that I saved someone's life actively,
mm-hmm.
I think that feeling alone kind of makes you feel like you feel like this, almost, you feel good about it.
Mm-hmm.
So you get really good positive feedback from your career.
Okay.
And when you go home, you're just really satisfied with yourself. I think that's what made me do it. And I think being an expert in something just kind of, I wanted to be an expert in anything, honestly. And when I was starting off, everybody's kind of pushing you to go to nursing. So you're like, everybody in my family, everybody's going to nursing. So I'll do nursing.
Yeah.
And when I started looking into it, I was like, well, nurses are really good at everything they do,
mm-hmm.
but there's not one thing that they're specialized in, unless they're in the tele floor, then they specialize in the heart.
Mm-hmm.
Or, there are neuro floors, but for the most part, it's not like they're an expert in the heart. It's more like they know the heart really well, but they're not an expert in it. And so I kind of was like, what's the closest to a doctor I could be without actually having to go to medical school? And I just kind of was respiratory.
How long have you been an RT or respiratory therapist? Because you said you wanted to be an expert in something.
Okay, so I've been an RT for 5 years now.
Okay.
5 years officially, I think a month ago or two months ago.
Dude, because you sound like, when you're talking about it, you sound like you love what you do. Like, just listening to you is like, dude, I could learn some stuff from this dude,
I think we, in our profession at least, you get to see science work. And so an example of that would be when somebody's on a ventilator and I'm breathing for them.
Yeah.
One of the things that we do is we have to make sure that your pH of your blood is a very specific mark. Do you know what pH is?
Yes, I know what pH is. pH is like the acidity of the blood.
Yeah. So, pH is acidity.
Yeah.
Okay. Now, so what we have to do is we have to make sure that your blood is going to be a pH of 7.35 to 7.45.
Okay.
7 is neutral. Anything less than that is way acidic or acidic. Anything more than that is alkaline. And so a lot of people right now are drinking alkaline water. It's pretty much just salt water. Just add salt and it's alkaline. Really? Yeah. Like, people are like,
they're paying like extra dollars for it.
Exactly. And then I've seen like these tests where they put like it's a pH test and they're like, oh, this water is purple or whatever. That means it's bad for you. And it's like, no, that just means it's a little bit more acidic. And the only way to make it less acidic is add a little bit of alkaline, which is salts. And so it's like, what do you'll see pH 8 in this water and it doesn't really do anything.
Okay.
But your blood has to be specifically 7.35 to 7.45. If you see 6.9 or 7.0, the patient's probably going to die.
Really? It's that
critical, that tight of a margin.
Wow.
And so typically, let's say somebody's been down. A lot of people that get brought in were laying on the floor for about 10, 20 minutes. And some family member called 911. They bring them in. They start doing CPR to get the blood working. And they come in, we draw their blood, and it's like 6.9. And we're like, oh, this is very little chance that they're going to be alive. So we put them on a vent. And now I have to blow that CO2 off. And how I do that is I control the size of your breath and how frequently you breathe. But I also get to control how fast the breath comes in, just pretty much everything about the breath.
So all those things play that much of a critical role?
Yes, you're sitting there and you're thinking about every little thing, and
the
especially
size of the breath, the length of the breath,
the length of the breath. We have this thing called I time, is how many seconds is the breath going to be delivered. You're looking at the wave pattern of the actual pressure pattern of the breath.
Dude, that's crazy.
There's like, do you want to give the first pressure and then slowly wean it off, or do you want to give a plateau pressure? And everything changes the dynamic of how well you're going to oxygenate, how well you're going to ventilate. Everything also plays in with what kind of disease you have. So a person that has cancer, lung cancer, we're going to have to put different settings than a person who has COPD or asthma. Everyone is going to be different, and everyone has to be managed fine-tunedly. Now,
that's so much.
It's cool. Now, what's cool about it though is you do the ABG.
Yeah.
And you see the acidity level, and we have a calculation that we do. We do a little bit of like thinking, and then you put a number into the vent.
Okay.
And within 30 minutes to an hour, you should see results. And it feels really good when you come back and it's exactly perfect, 7.40.
Yeah.
And you're just like, yep, that was just simple science. And I think that it makes you feel like an expert in what you're doing.
Yeah.
And that's where I'm at. And like in terms of, I feel really happy about my job.
Yeah.
So I wouldn't say I'm an expert in lungs. By a long shot, I'm not.
Yeah.
There's pulmonologists out there that just know everything about the lungs.
Pulmonologists?
Yeah. Pulmonologists are doctors that specialize in lungs.
Okay.
So typically in ICUs and intensive care units, you'll have pulmonologists working there. And then so just talking to them for 5 minutes, you're just blown away. You're like, what do you even like? How do you know this? You think you know something, and then you talk to a doctor, and you're just like, okay, I'm just gonna turn around right now.
Dude, that's interesting. A pulmonologist. I have no idea. What does pulmonology have to do with lungs?
Well, pulmonology means respiratory system.
That's what pulmonology means.
Pulmonology is the respiratory system, pretty much studying of the respiratory system.
Okay.
So a pulmonologist is someone who knows the respiratory system. And that's a whole career in itself, is just pulmonology.
Yeah.
It's cardiorespiratory system, so it's also a little bit of heart involved. But either way, with that being said, it just being able to put in a number, control the breath, and then seeing a result, and you're like, okay, I did something. I know what I'm doing. And that's being a respiratory therapist. So I push everybody to be an RT that I know.
Yeah.
There's only about 40,000 RTs in the United States.
Really? Okay.
There's no RTs in Russia, Ukraine.
Get out of here.
Yeah, they don't have this profession. They're still in a very primitive stage of medicine, in my opinion, at least. I don't want to offend anybody that's a diehard patriot. But like,
I mean, dude, you gotta accept the fact if that's the fact.
Yeah, so. I mean, it's funny because sidebar.
Yeah, I
know a lot of people from Ukraine, and they swear on it, but they say that Ukraine has the best healthcare system.
Yeah.
And then they tell me that their relatives got sick and they got flown out to Germany. And I'm like, well, then why did they get flown out to Germany?
Right.
Not to say that their healthcare system is bad. I think they have good doctors.
Yeah.
A lot of the people I work with are from there. Actually, they study there and they're really good. But the healthcare system, I would say,
can improve.
I would say that it would be it needs improvement.
Yes.
With that being said, though, Dubai, Israel, Canada, they have respiratory therapists, but most of the world still has not done this. So they'll have like a nurse that's specially trained on ventilators, but then that takes a lot away from their ability to be a nurse. And so this career is still a new career. It still has a lot of room to grow. And our scope of practice license gives us the autonomy to do a lot of things. But we're still such an infant, like in an infancy stage of a profession, that in about 20, 30 years from now, we might actually become all like physicians. We're still not there yet. We don't know where we're headed. But as a profession, it seems like we're headed to that place.
That's interesting. That's just like last week we had a physical therapist on, and now there was a switch to where to become a physical therapist, you need a doctorate degree.
That same switch happened in us. So at this moment in time, you could still become a RT with an associate's degree, but it's soon supposed to be that you have to have a bachelor's degree.
Okay.
And then after that, next step is master's degree.
Yeah.
So that switch is we're in the process of that switch. And I think within the next decade, it'll already happen. And like I said, in the next 20, 30 years, the next switch is going to happen.
Yeah. Well, because I mean, that's kind of crazy to think that it's been around for 50 years and you're saying it's still in an infancy stage, but I'm sure these 50 years pass and then plus 20, every year, everyone just learns so much more in depth and like how to become better. And you pretty much do become not a physician, but a doctor in the lungs or in cardiac arrest because of all the trial and error that we've been having all these years?
So we are officially called the Respiratory Care Practitioners. Our title is Practitioner. The funny thing is when the profession was just starting, they were called oxygen jockeys. So actually how the whole career started was somebody needed to carry oxygen tanks. And so these guys would carry oxygen tanks and they were called oxygen jockeys. Well, somebody was like, hey, we don't have enough staff. So can you also administer the oxygen? And then they're like, okay, we could do that. And they started getting more and more things that they could do. So they started calling them inhalation therapists. And after a while, they're like, okay, well, now we actually want you guys to actively be always in the hospital. And now you're going to do this. And the role kept expanding. So in the 80s, they're like, all right, now you guys are going to be called respiratory care practitioners. And then in the past 40 years, it's just exponentially grown.
That's kind of cool how like there's certain positions in the hospital over the years that have been diminishing, and then certain positions that have been expanding or brand new positions, you know? That's really interesting. So what would you recommend moving to the how can I part, like somebody listening, it wants to be in the medical field, recommendations, suggestions, tips, like what would you offer to them?
So for most people that are, first of all, I encourage everybody to go into a profession. It doesn't necessarily have to be medical, but I think if somebody's trying to be in the medical profession for the money, I think they should not do it.
Okay.
There's a lot of people that I've seen over the years that I worked with and that I've encountered with that were in it for the money. And you could actually see it shows with how badly they perform. And if you're in a profession just because you want to get paid paid well, English is my second language. If you're in a profession for the monetary gain, you're not going to care as much about the little nuances of the job. And you're also not going to care about what you do and what your results are. And so first of all, if you want to get in the medical profession, make sure that you actually want to do it for the right reasons. And again, not because of money. I just talked to a lot of people that are going to nursing and I'm like, what draws you to nursing? And they're like, the money, man. And you're just all right, that's what,
you're not going to last.
Yeah. Why don't you just
see, but that kind of explains why I heard like a statistic, and I don't know if I'm being accurate, but on average, every third nurse or something quits her job on like the third year or something like that because they end up like, okay, yeah, the money's good, but I actually hate my job.
I would trust that statistic very heavily because a lot of people go into it because the school part of it, it's easy. School is definitely difficult, but you don't really actually see the patient in front of you dying or the patient in front of you surviving, or, you don't see how difficult you have to actually work. And I would say that once the people actually start working, they realize that by being in it for only the money, they're like, no amount of money will pay for me seeing people die every day. And so my first recommendation is if anybody's trying to go into the medical field, do it for the right reason. My next one is if they're trying to go specifically for respiratory, most people that are listening to this are probably going for nursing or they know about nursing. That's like the go-to. And I think it's just because in our hospital, there's about 100 RTs, almost 100. And for the 100 respiratory therapists that we have, there's thousands of nurses. And so there's just so many more nurses. Also, they expand. You could be a nurse practitioner. You could be nurse anesthesiologist or anesthetist, whatever.
So nurse is like kind of the base. A nurse is, you become a nurse, you become a basic nurse, not to disrespect.
But you're going to get some angry emails tonight.
but to, there's nurses can expand into broader, different departments in the hospital or something?
So because nursing has been around for so long, they've had more time to establish themselves. And because of that, I guess nurse is just more of a general statement. And again, I think the best way to define it is a nurse is the hands of the doctor. And so you could be the hands of a doctor in a clinic. You could do that in ICU. You could do that in AED. But because there's just so many opportunities for them, they get to expand into a specialized career. And so there's just a lot more opportunities for a nurse. You could also go from working in an office. You don't even have to work as a nurse. You could work in administration as a nurse. And now as an RT, it's going to be a little bit more difficult because our job is specifically fine-tuned to just working in the hospital. There's a few outpatient kind of clinical things, but for the most part, we're hands-on. you can't really be on life support outside of the hospital.
Right.
Well, the people that are in home care, they can, but so as a respiratory therapist, your focus is going to be, you're going to work in the hospital. Your focus is going to be to work in the hospital. Mm-hmm. As a nurse, your focus is to work everywhere.
Okay.
So with that being said, I would say that if anybody's trying to become an RT, again, with that in mind, that everybody's probably trying to be a nurse. Mm-hmm. If they like adrenaline rushing scenarios, mm-hmm. you're going to get a lot more of that as an RT. Okay. And now you do get a lot of that as an ICU nurse, but it takes years to become an ICU nurse. That's like top of the line, mm-hmm. in my opinion. Okay. Next thing is, if you want to work 3 days a week and have a pretty good flexible schedule, mm-hmm. that's another reason why you should become an RT. Whoever's trying to, actually is interested in this. And
actually interested in patient care.
I would say if you're interested in patient care, it depends on what you mean by patient care. There's so many different.
If you check the box of like, yes, I want to work with patients because I love working with patients and saving lives, then the next thing would be like the schedule. Now, if you're trying to pick a different field, like in the hospital, okay, schedule is better in this department, I want to go there.
Well, I wouldn't say the schedule is the only thing, because you could also find a nursing job that has a 12-hour shift. Okay. It's just going to be a little bit harder, I guess, from my experience. Mm-hmm. I would just say if somebody's having a checklist for being an RT, the first thing on that checklist, in my opinion, would be, do you want to have an adrenaline rushing situation happen often? Mm-hmm. Or do you want more steady work? You care for the patient. You really bring the person back to, being normal. Mm-hmm. But you don't necessarily get to see a lot of that adrenaline rushing mm-hmm. kind of stuff. If that question you answer the fact that you want adrenaline, then I would definitely recommend looking into respiratory. Mm-hmm. Also, if you just want to become like an expert in something, I think it's just easier to become an expert with something that you're exposed to all the time. Mm-hmm. So because you're an RT, I hear about lungs 24/7 on the job. I mean, not 24 because 12/7, 12/3. 12/3. But I hear about lungs so much that you're eventually going to start picking up studies. And again, there's only so much you could learn at a time. Mm-hmm. But because it's only in one field, you really start stacking your knowledge, and you develop a place where a nurse talks to you and gets your advice, or a doctor talks to you and they're like, what do you think about this? You see the situation very often. And so if you want
that's kind of nice.
It's a good feeling. Yeah. It doesn't happen all the time, but
when it does, you're like,
you just want to go pat yourself on the back. You're like, did the doctor just ask my advice? Yeah. It's definitely. You call your mom. You're like, hey, I made it, Mom. This is it. I could retire now. Yeah. Another thing that, the one thing that's discouraging about being an RT is you don't have the option to expand. Mm-hmm. Again, you're only limited to mostly working in the hospital. That's mm-hmm. a big downside. The funny thing is, I actually have videos on my YouTube channel about 5 reasons why you should be an RT, or 5 reasons why you should not be an RT. Okay. And
what's the how to? So those YouTube videos are like kind of in detail specific towards RT. Where can they find those videos?
So I have a channel called Doldier Media. Mm-hmm. I just recently started doing a channel about respiratory stuff. Mm-hmm. So I'm trying to teach a lot of people that are not familiar with respiratory, mm-hmm. Teaching them the basics of it. But also, if you're going to school, or even if you're a nurse and you want to know more about it, I go over some basic knowledge things to better equip them. And also, I dabble in a little bit of theology on my channel. Okay,
so Doldier Media, how do you spell that?
It's like soldier with a D, Doldier.
Soldier Doldier.
Doldier, yeah, Doldier Media.
Soldier. Okay, Doldier Media, you guys could check him out, subscribe, like. He'll be coming out with some awesome content, so for sure.
Yeah, man. I love this. I love what you do here, man. I really want to see a lot of people come out here that are professionals. I think what you're doing is great. I think we need more of this.
Thank you. I appreciate it. Hey, thank you. Honestly, you talked to me last week. We set this up real quick, so I appreciate you coming out, making time, first of all. Oh, no, I know you have a family. I have a family, but, for the greater good, we have to make these things work together, so.
I love coming out here, man. Honestly, you've been great.
Awesome.
Definitely looking forward to seeing you again, man.
Yes, sir. Have a good night.
You too, man.
Peace.